Hello, everyone. I'm Dr. Bill Schaffner. On behalf of CME Outfitters, I'd like to welcome and thank you for joining us for today's educational activity, which is titled Giving Shingles Immunization Your Best Shot, Implementing a Shingles Vaccination Protocol in Your Practice. Today's activity is brought to you by CME Outfitters, an accredited provider of continuing education for clinicians worldwide. Today's CME CE activity is also eligible for ABIM MOC points. So make sure you engage in today's event. Once you complete today's program, be sure to provide your ABIM ID and birth date in the evaluation. CME Outfitters will submit your MOC points. As I mentioned, I'm Dr. Bill Schaffner. I'm Professor of Preventive Medicine and Professor of Infectious Diseases at the Vanderbilt University School of Medicine in Nashville, Tennessee. Let me introduce our faculty. Joining me today is my colleague, Dr. Anthony Cunningham. Tony is Director of the Westmead Institute for Virus Research and Professor of Medicine and Health at the University of Sydney Medical School. Tony is also the director of the Australian Centre for HIV and Hepatitis Virology Research and the New South Wales Australian Capital Territory State Branch Chair of the Australian Academy of Health and Medical Sciences in Westmead, New South Wales, Australia. Welcome, Tony, and thanks for joining us from Australia.
Thank you, Bill, across the Pacific.
I would like to introduce also my colleague, Dr. Iris Gorfinkel. Iris is founder and principal investigator at Prime Health Clinical Research in Toronto, Ontario, Canada. Welcome, Iris, and thanks for joining in from Canada. Yes, good to have you. So let's review our learning objectives. Our first learning objective is to identify the primary risk factors and the clinical and quality of life complications imposed by shingles. Our second learning objective is to more frequently and effectively educate eligible patients about shingles and shingles vaccination, and to improve their uptake of vaccination and series completion for shingles vaccine. Our final learning objective is to apply real-world strategies to implement shingles immunization that considers safety and efficacy of available therapies, storage and administration, and pharmacy-based vaccination. So let's start. I'd like to get you, our audience, somewhat involved here. The question is, which of the following is accurate regarding the risk of shingles? Your answers are A, there's an increased risk in males. B, after age 50, there's no increase with age. C, there is about a twofold increased risk in those with HIV. D, African Americans are not at higher risk compared to their white counterparts. And E, I don't know, beats me. I'll review these results with you a little later in the program. So Tony, let's start with you. What are some of the key risk factors for herpes zoster of which clinicians should be aware, please?
Bill, the most important risk factor for herpes zoster is increasing age. And there's been a lot of discussion about whether this might be less opportunity for boosting, particularly since we've had the chickenpox vaccine in Australia, Canada, and the USA, and less frequent exposure to kids with varicella. But clearly the most important factor here is so-called immunosenescence or declining immunity with age. Of course, we now know that important other factors are involved in risk for herpes zoster, particularly those of us who practice in hospitals. Cell-mediated immunosuppressive disorders, hematologic malignancies, immunosuppressive drugs, HIV, before antiretrovirals about 12 to 17-fold, still about 6-fold with antiretrovirals. Interestingly, there's a greater risk in women than men, and surprisingly, risk in African Americans is less than half that of whites. Trauma or surgery in the infected dermatome is, of course, well known to most of us. And a really interesting factor is that if you get early chickenpox, particularly in utero or early infancy, you'll get sometimes early zoster. And the youngest I've seen is 7, but the literature documents 3 years old for a case of herpes zoster. Thanks, Bill.
Very good.
Tony, thank you so much for pointing that out. What's so surprising about that, I want to point out to the audience, is that African-American risk is less than half of that of whites. That is a notable exception to the regular social determinants we see of health, where generally African-Americans suffer way more. Here, it's less than half of whites.
Good point. Glad you emphasized it, Iris. And we all agree that herpes is more than just a rash. And so let's have a look at an animation. Shingles is more than a rash. The impact of shingles can be extensive and include the cerebrovascular system. For example, some research has indicated an increased risk of stroke in individuals who have shingles, with the highest risk within the first month after shingles onset. Shingles can also have a neurologic impact. It can result in meningitis and/or encephalitis, as well as paresis of the extraocular muscles. In addition, individuals with shingles can also develop peripheral neuropathies, causing paresis of the gut, as well as paresis of the diaphragm and of the bladder. The pervasive nature of shingles may also result in damage to the ophthalmic system, such as ocular lesions of the ophthalmic division of the trigeminal nerve, as well as conditions such as glaucoma, ptosis, corneal ulcerations, conjunctivitis, and lid retraction. Though shingles is often associated with a rash, it can also lead to secondary skin infections. The gastroenterologic system can also be impacted by shingles. The result can vary from abdominal pain to constipation. Shingles has also been associated with major gastroenterologic conditions such as inflammatory bowel disease. Overall, the key message is that shingles can be extremely debilitating, and vaccination is critical to reduce the disease burden.
So I think we're now talking about the incidence of herpes zoster. And you can see here, as I mentioned before, the marked difference if we look going upwards from grey to brown, the marked difference in the incidence of herpes zoster with age, markedly increasing, in fact, almost a 3 to 4-fold increase to 15 per 1,000 cases on admission, which is really pretty high. And you can see this remarkable increase in the incidence of herpes zoster over time. This has been documented in all high-income countries. People at first thought this might relate to chickenpox vaccination and the absence of boosting. That's not the case. It's probably got something to do with the aging of our population, but it's still got many of the epidemiologists stumped. Of course, this is now declining with shingles immunization, and we'll talk more about that later on. I think Iris is going to say something about this in the next slide.
This is an absolutely fascinating slide. I want to point out that this data was collected out of Kaiser Permanente. So what you're seeing is, in fact, a bit of a selection bias. You can see it's biased toward the younger patient population. What we would normally expect is to see the curve increasing with every passing decade. The incidence of herpes zoster goes up with age. And in fact, our most risk patients are those who are the most immunosenescent, those who are over 60, aggressively over 70, 80, et cetera. What we see here in this slide is a selection of younger patients because it is a selection of patients from Kaiser Permanente. So here we can see, I think the main take-home message of this slide is one thing. Look how common it is in younger individuals. In fact, that does carry a very significant burden of disease. The patient who's over 50, and you can see how it actually peaks and then it goes down a tiny bit. It's a relatively small population, that of the Californians, but the take-home message is it is not just a disease of the elders and super elders. It is a disease that can, in fact, infect younger patients. And I think most clinicians have seen it even in patients in their 40s. If we go to the next slide, what's fascinating about this is looking at the cumulative incidence of herpes zoster in an immunocompetent, unvaccinated population. Now, this is recurrence. So in other words, they've had it once, and what happens? Can they get it again? So the common thinking is, no, people don't get it again. But if you take a look at this graph, in fact, we can see that individuals do get it again. And the likelihood of getting it again depends on how far away they were from the actual infection. This suggests that actual infection does give some immunity, but it is not long-lasting immunity. They can, in fact, get a second episode.
Right, I think we're going to questions now for the audience. Which of the following do you think is accurate regarding the risk of shingles? There's an increased risk in males. After age 50, there is no increase with age. There is about a twofold increase in those with HIV, and African Americans are not at higher risk compared to their white counterparts, or I don't know. And in Bill's words, beats me. Bill, I think you're back with us. Would you like to take over?
What I find absolutely fascinating about this is I'm going to focus on answer number C for just a second. There is about a twofold increased risk. It is absolutely striking. The increased risk is not just twofold. Tony, what did you say about the increased risk in HIV individuals?
Well, as I said, before antiretrovirals, it was as high as 12 to 17-fold. It's dropped with antiretrovirals, but the risk is still there. And we'll talk a little bit more about the role of shingles vaccination later on in patients who have HIV, and obviously an important group. But Iris, flicking back to you, the audience has rightfully discerned that answer number 4 is the dominant one. And this is what we said before, a surprising risk that whites actually suffer more zoster than African Americans.
It's such a notable exception because, again, not to overly emphasize the effect that disease has on American Blacks, but it is absolutely incredible. We see that across the board. It's highly exceptional in disease. And in fact, we know that the burden of COVID-19 deaths has largely fallen on Blacks. It's very exceptional. Tony, would you have any idea why that might be?
No, I think it may relate to, of course, shingles is a recurrent disease. And it may relate to the prevalence of chickenpox, declining immunity, etc. But the answer is, I don't know. I really don't know. Something that needs to be looked at in more detail. We better move on.
Yeah, well, here's something that we can talk about that we do know. I'm going to try to do this. Tony, let's shift gears. Why not talk about the clinical manifestations of classical herpes zoster?
Right, thank you indeed, Bill. Well, the prodromal phase of acute pain, and remembering that the pain of herpes zoster can be worse than that of childbirth, and developing dermatomal pain in the thoracic region or in the abdomen can be mistaken for cardiac disease or for an acute abdomen. So watch out for the prodrome. It doesn't occur in every person. And I'll come back to that in terms of risk for postherpetic neuralgia later on. The acute phase, which lasts about 4 weeks, 3 to 4 weeks, but can be very mild, is characterized by pain, which can be neuritic, lancinating, or burning, and is characterized by a dermatomal rash anywhere in the body. So abdominal, thoracic, in the head, in the leg, but characteristically dermatomal, and it is goes through a phase like chickenpox of papules, vesicles, and crusting, and often evolves from front to back. So if you have thoracic zoster, you'll see crusting on the back, and on the front, you'll see vesicles, but very clearly a vesicular rash. That's the characteristic. Complications, most commonly skin, and postherpetic neuralgia. The most feared is postherpetic neuralgia and the eye complications of zoster, Bill.
So Iris, let's go back again to that sample of Southern California patients. What did they discover about herpes zoster that you in particular would like to emphasize and found striking?
I was surprised that it's a cause of death and a cause of hospitalization. These things occur, but they are rare. The take-home message of this slide is cutaneous complications rule. That's what people are experiencing. There are hospitalizations, and another thing the slide demonstrates quite nicely is that we see the biggest burden of disease in the most immunosenescent of patients. So as patients get older, you can see that in orange. See how high those bars are. That tells you that immunosenescence is in fact playing a very significant role. And the postherpetic neuralgia pain should not be underestimated. It is a very major problem in individuals' lives.
And so, Tony, what would you like to add to that regarding herpes zoster associated pain and actually the risk factors for postherpetic neuralgia?
Yes, so the risk factors for postherpetic neuralgia are in particular age, Bill. But let's talk about the pain first, and that is that it can be quite deceptive. It can persist, and this is pain beyond 90 days, as you can see in the last point, after rash onset is defined now as postherpetic neuralgia. That's shifted around over the years, but this is a very clear definition. Of course, you can have pain also between the cessation of the rash, which is about 30 days, up to 90 days. That's subacute pain, but postherpetic neuralgia is defined as that over 90 days, and it can disappear and come back. It can change its character. Neuritic pain, which represents the nerve component, and also it can be burning and assume other characteristics as well. The cause of it is not clearly defined, but we do know, stuff that we've published, is that the virus causes inflammation and necrosis in the dorsal root ganglion near the spine, but it affects the whole of the nerve. It goes back into the nerve root, and this results in scarring. It results in aberrant nerve conduction, and this can result in really quite severe pain, which may be complicated by light touch causing pain itself. And the risk factors for it are age, particularly increasing age. So you rarely see post-herpetic neuralgia under the age of 55. There's little inflection over the age of 55, but then it goes up very, very quickly. And in fact, in people over the age of 80, about 25% of people will have post-herpetic neuralgia, very age-related. Women more. We used to think it didn't occur in immunosuppression, but it does. And it's exactly the same as occurs in immunosuppression or immunosenescence with advancing age. And of course, that also relates to other milder immunosuppressive conditions such as autoimmune diseases and asthma. What predicts the occurrence of post-herpetic neuralgia? The presence of a prodrome is highly predictive, and severe acute pain. So if you see someone with a prodrome and severe acute pain, watch out for post-herpetic neuralgia, particularly if they're over the age of 70. In our shingles vaccine trials, almost all the cases of PHN were seen over the age of 70, but you can get it from 60 upwards. Thank
Tony,
you.
I think that is such a big pearl. The presence of prodromal pain predicts post-herpetic neuralgia. Can we concentrate on that for just a moment? And I have a question for you as a family doctor, actually, which is, if a patient has horrible pain, should we be giving them a dose of corticosteroids? Has that been shown to be helpful?
Well, that's a very interesting question. Corticosteroids has been shown many years ago to assist acute pain, along with all of the other pain relief. And we go through in terms of, I don't want to turn this into a pain lecture, but there's a clear hierarchy of pain relief that one goes through, right through to the need for opioids. As I said before, this can be incredibly severe. Steroids can be useful for acute pain. They are not useful for PHN. Don't use them. They're clearly shown by controlled trials not to be useful for PHN.
Thank you.
So Iris, you know, there's an aspect of herpes that goes beyond pathophysiology. It's one of the things that you emphasize all the time and I think is often overlooked. So talk a little bit about the quality of life that's impacted by shingles.
I think when approaching patients who have this, there's really one way to approach it, which is optimized, and that is the biopsychosocial model. And I think for any doctor who tries to overlook one of those aspects, we're not doing our patients the best service. So it's not just a physical pain that needs to be addressed. We know that chronic pain holds hands with severe psychological problems, potentially. Of course, it interferes with their sleep, and therefore can cause difficult concentration and depression and potential anxiety. The social aspects should not be overlooked also. If someone is having a lot of pain, that can impact on their socialization, on their willingness to go out, on their willingness to see other people, which in turn can, one just feeds right into the next. That can aggravate their depression. They can actually interfere with their sleep. Just the social losses can. So I want to point out in this slide, the functional, psychological, and social losses, actually one thing feeds right into the next. They should not be viewed as separate problems, but as one problem altogether. And just a simple question, hi, how are you doing? And then for the patient who focuses solely on the pain, asking them specifically about these other areas is hugely helpful in optimizing the care provided to these patients.
Actually, if that were not enough, in addition to the quality of life impact, is an economic impact. Say a few words about that.
Thank you, Bill. If we take a look at the economic impact on this slide has three different categories. And what you'll see to the far right is the patient who's impacted by post-herpetic neuralgia. And this is often the patient who can afford it the least, the older patient. Look at the economic burden. In all categories, it's in the many thousands of dollars. but it's especially acute in the patient who has postherpetic neuralgia. Not surprising, the least economic burden happens in those individuals who have zoster but have no postherpetic neuralgia. And then here we can see the overall impact of shingles in patients. So the take-home message from this is not to memorize how many thousands of dollars it is, but it is a very significant economic burden, both to the patient and to the healthcare system.
We've all decided that herpes is not a good thing. So let's change the focus now on to the rationale for a shingles or a herpes zoster vaccine. Tony, you and Iris have brought up some good points on the impact of the disease itself. So now tell us about the data that support the need for a vaccine.
Bill, one of the things that happens to us as we get older, particularly I think to you and me, not Iris, is a decline in our T cell immunity and B cells called immunosenescence. And this is a fascinating condition which is not well documented, but it actually involves shrinkage of our lymph nodes and some degree of scarring. And in those lymph nodes, the interaction between the immune cells is important. And so this gives rise to impairment of the function of all branches of the immune system, innate, B cell, T cell. But antibody stays up because we're just little antibody factories. T cells drop off to the chickenpox virus. And so cleverly, Mike Oxman and Myron Levin decided to run a trial to boost this T cell immunity and reported it in 2005 with some preliminary data beforehand showing that they could reboost with a live attenuated concentrated chickenpox vaccine T cell immunity. And I remember sitting on Mark Oxman's couch as he described this to me and thinking, you'll never get this up. He did. He did the trial in 30,000 people and showed the principle, which is wonderful.
You know, this is incredible looking at this slide. And the impact on T cell immunity is profound as we get older. And you can't help but wonder in this day of COVID-19, is the same impact, is that why we're seeing this,
Absolutely.
Chronic patients and patients with, over the age of 60, carrying the burden of disease. Here in Canada, the deaths took place almost solely in long-term care institutions in which patients do suffer from many chronic diseases.
So
Same
now
in Australia.
go ahead, Tony.
I was going to say it's the same in Australia, and I agree with you entirely. And I think we're using the example of the shingles vaccine to produce a vaccine that's aimed directly at the aging, and that must be involved not only at antibodies, but also at T cells.
Sure. So now we're going to involve the audience again. I have a couple of questions for them. Let me read the first one. To the audience, how confident are you in implementing shingles immunization protocols that consider safety, efficacy, administration, and storage? And your answers are A, extremely confident, B, confident, C, somewhat confident, and D, not at all confident. So have a vote and we'll discuss these results in a moment. Thank you. So here's the second question. How many vaccines are currently FDA approved for shingles? Your answers are 2, 3, 4, 5. Beats me, I don't know. And Tony, why don't you chat about the results?
So we can see here, people have said, the majority say that 81% say there's only one FDA approved vaccine for shingles. 6% said 2, and they are correct. In Australia, it would be the people who said 1 would be correct, but because we don't yet have the recombinant zoster vaccine. But the correct answer is 2, and Bill will talk about that in just a moment. Perhaps the reason for this is going to become apparent on the next slide, Bill.
Yes, exactly. And that's because the CDC's Advisory Committee on Immunization Practices made some recommendations recently. And the first is they absolutely recommended for immunocompetent adults age 50 and older, they should all be vaccinated against zoster. Number two, they said if you've been vaccinated previously with the live virus, you should now be vaccinated again with the recombinant vaccine. Indeed, they made a preferential recommendation, very unusual for the ACIP. They actually made a preferential recommendation for recombinant vaccine. So, Tony, we know now that in the United States, zoster vaccine live, ZVL, is no longer being manufactured as of July 1st this year. Some pharmacies and clinics likely will still have it in stock for a period of time. But you were part of some of the pivotal vaccine clinical trials. So what do we know about the relative effectiveness of RZV, the recombinant vaccine, particularly in comparison to the live attenuated vaccine, ZVL?
Yes, and people should know that you're fortunate, and again, this relates to COVID vaccines and the rollout of the recombinant RZV, has been reasonably slow because of bottlenecks with the immunostimulant or adjuvant in it. And so it's available in North America and in Europe, and soon will be in Japan and China, but Australia is still waiting. So North America is in a fortunate position of having this new vaccine. The reason for this is well shown on this slide, that if you look at the first column that shows the efficacy against shingles, firstly, in the first three rows, that it declines from 70 to 38% in the 10-year age cohorts from 50, 60, and 70, whereas the RZV, I'm using Z, not Z, Bill. Yeah, and I'm learning. It's my old American roots back at Stanford. So RZV is in fact 97% effective. Now, in subsequent trials that appeared to drop, but in fact the confidence intervals were the same. So let's just say it's more than 90% effective, and it's more than 90% effective in those over 70 and those over 80, which is remarkable, and that's because of the immunostimulant or adjuvant in the vaccine. Now, with the live attenuated vaccine, interestingly, there was not the same drop in the efficacy against post-herpetic neuralgia. So it actually had an additional benefit in attenuating the disease of people who had breakthrough on the vaccine. And that's true for PHN as well. With RZV, it was so effective that you couldn't detect any such effect. So its effect on PHN was due to its effect on zoster, but still much greater than ZVL, and that's why the ACIP made the decision it did.
Tony, I just would like to interject one very small thing just for our audience. You know, it's my family physician brain in action. So I just want to point out that RZV is also called Shingrix. That is the trade name. We are referring to it by RZV, but that is known as Shingrix. And ZVL refers to the older vaccination, Zostavax. I just want to clarify that for the audience.
Yeah, so while you're up, as it were, Iris, say a little bit about how impressive that efficacy is in people older than 50 and indeed older than 70. That's spectacular. We're talking about immunosenescence in old people, but this vaccine with its adjuvant has overcome that problem.
I have to share with you, I still remember because we were also part of that very exciting trial. And when we heard the efficacy, it was unbelievably exciting. It is highly unusual to see a vaccination which is this effective, and also against a disease which is a common disease. Here we see a vaccination, the RZV, which is taking what is now a common disease and turning it into a rare event. Extremely exciting. This means saving a tremendous number of people, a tremendous problem.
I think,
Yeah.
Bill, the other key issue here is, as we discussed with COVID and influenza, the principle of just a single protein, as opposed to all of the proteins, which the live attenuated virus has got, and the immunostimulant. The immunostimulant is it. If you actually look at the phase 2 trials, if you did not have the immunostimulant there, the efficacy drops below 20%. So it's really created a revolution in thinking about vaccines for the aging, and now we have flu vaccines that differ for those over 65 and under. And I suspect that might happen with other diseases and may even happen with COVID in the future.
It's
Oh.
absolutely fascinating because you look at, and it just goes to show you, predicting the mechanism of how a vaccine will work is not what we need to be doing. This vaccination trial, if it is probably the best representation of a vaccination trial that we have. There are many, many different areas in which it's basically one and the same. It affects the same age group. We see, an increasing amount of disease burden with COVID, as we do with shingles, with increasing